Hi, everyone. My name is Dr. Argyrios Stampas. I'm an associate professor at the Department of PM&R at UT Health at Houston at TIER. And I'll be talking to you today about the management of neurogenic bladder and spinal cord injury. I have no relevant financial disclosures. We're going to start with the conclusions because I know how difficult it is to pay attention to lectures that are online. Then we'll get into the background of neurogenic bladder, the gaps in the knowledge, some fake news about neurogenic bladder, and also the management of neurogenic bladder. Okay, so conclusions. Assume everyone with spinal cord injury has a neurogenic bladder. We'll talk about that. The physical exam of spinal cord injury does not reflect the function of the neurogenic bladder. So the management of neurogenic bladder and spinal cord injury must be individualized based on patient history and neurodynamic studies. Do not treat a positive urinalysis and culture in an asymptomatic patient with spinal cord injury. And finally, you have to monitor the bladder status. Because uncontrolled neurogenic bladder may lead to irreversible changes, which will increase morbidity and decrease quality of life. So let's talk about what we know. This is a busy slide, but I like it because we can basically put everything we know about neurogenic bladder on like 2 slides. So when we talk about neurogenic bladder, the first place I like to begin with is storage. Storage of urine is dominated by the sympathetic nervous system. That's going to be at the T11 to L2 area through the hypogastric nerve. And this activates the adrenergic receptors. The beta ones are in the body and the alpha ones are in the base and in the neck. When these are active, when the betas are active in the body, they allow for storage, so they relax the bladder. Meanwhile, these alphas, when they're active, they actually contract. So they allow for continence. They close the outlet, and now you can effectively store. And the hypogastric nerve carries efferents to the bladder and afferents away. Now, once the bladder is full, signals have been sent and the body is aware. So at the frontal cortex, we are notified that we have a full bladder, and then now we find a place and we give permission to void, right? So signals are sent to the brainstem at the pontine micturition center. The cerebellum is also involved, sending signals to this area here, which coordinates the emptying of the bladder. Signals are sent down the spinal cord to the sacral micturition center. And now we're in the parasympathetic areas, which control voiding. So that's through the pelvic nerve coming from S2 to S4. And they innervate the muscarinic receptors in the detrusor. So in the body, largely in the body. When these are active, they contract. But also when the parasympathetics are active, they reflexively inhibit the sympathetics. They also stimulate the pudendal nerve. The pudendal nerve is controlled somatic nerve, and that innervates our external sphincter that we have control of, and that's when we give permission to void, we relax this external sphincter. This is still an oversimplification because the musculature of the pelvic floor is very important in continence. In order for physiologic micturition to occur, there's a reflex coming from the bladder afferents to the nucleus of the pudendal nerve, which should be around here. And this inhibits the pelvic floor activity during voiding. And then obviously the opposite is true during storage. Those pelvic floor muscles are working to stay continent. We know that the physiology of micturition, we know a lot of it from urodynamic studies. So the first thing that we know is our first filling sensation. This is not a real life sensation. This is a product of a urodynamic, but this can be abnormal in neurogenic bladder, right? So in a non-neurogenic bladder, typical first filling sensation occurs at around 100 cc of fluid infused into the bladder. Fullness is achieved at around 300 to 400 cc's. And again, storing driven by the sympathetics, T11 to L2 through the hypogastric nerve, innervating the beta 2 receptors in the detrusor and the alpha 1s in the bladder neck. The body relaxes and the neck contracts, allowing for storage. Voiding, driven by the parasympathetics, causing detrusor contraction, originating from the micturition center, S2 to 4, along the pelvic nerve to the cholinergic receptors of the bladder, of the detrusor, and they're M3 receptor types. These do change, apparently, from acute to chronic phase. We won't get into that. So just wanted you to be aware that it's not always the M3 receptors. And that might speak to how medications may work initially and then later don't work. And again, there's reflexes that are involved where the parasympathetics inhibit the sympathetics, allowing for the outlet to relax. Important to remember that the pontine micturition center is what coordinates it. So the bladder empties without discoordination, and the sacral micturition center is reflexive. Now, how do we classify the neurogenic bladder? There's several different ways to classify it, but I like the anatomic way to do it. So there's a suprapontine area, so everything above the pons. That's going to be like your stroke patient. They might have this type of neurogenic bladder. It's an upper motor neuron type bladder and it's spastic. Then there's the suprasacral. That's everything above the sacral but below the pons. That's going to be our spinal cord injury patients for the most part. They too have an upper motor neuron type bladder, but because the coordination center in the pons has its afferents and efferents disrupted, it's discoordinated, and that leads to detrusor sphincter dyssynergia. That is unique to spinal cord injury. And then finally, we have our sacral or cauda equina type of neurogenic bladder. That's going to be a lower motor neuron type of bladder, and it's areflexic. You can also classify these bladders by function, right? Either their failure to store, like our suprapontine or suprasacral. They're hyperreflexive and they have decreased compliance. But the outlet also is denervated pelvic floor and the intrinsic bladder neck sphincter failure that may occur. And then there's failure to empty. So the bladder factors are areflexia and hypocontractility. And outlet factors include DSD, non-relaxing voluntary sphincter, and even mechanical obstructions like your prostate or strictures, for example, that can occur at the urethra. What's important to note, though, is that suprasacral can have components of both failure to store and failure to empty. So you may have this inability to store because of hyperreflexia, but also weakness when you do want to empty from hypocontractility. So every neurogenic bladder is going to be unique depending upon the damage that has been done to these pathways. So we know how these neurogenic bladders end up, but we really don't know how they get there, and we don't have a good way to prevent the damage from occurring long term. And the reason for this is because of a tremendous gap in the knowledge. So the example I want to give you is from our model system here at TIER. We're a spinal cord injury model system, so we're at the pinnacle of spinal cord injury care in the United States. We have to be the best in the country. And this is basically what we do. The number one reasons for spinal cord injury continue to be motor vehicle accidents and falls. Patients injured in this way, and they're brought to our level 1 trauma center where they have CAT scans performed of their head, their spine, they have MRIs, and lots of blood and urine laboratory work. Surgery may be performed, a Foley catheter is inserted. That's an indwelling catheter. Sometimes they're put in a diaper, unfortunately, but for the most part, they're put into a Foley catheter. Once they're stabilized, they're sent to rehabilitation, where we do even more studies like chest x-ray, abdominal x-ray, and more blood work and urine work. We move along in our functional and neurologic recovery, and that includes training patients on how to manage their bladder, whether it's timed voiding, intermittent catheterization, indwelling catheterization, and we might have to even start medications in this phase. But in a model system, there's even more stuff that we do. We do the Izinski Exam, which is a spinal cord injury exam, 3 times from when they're injured to when they're discharged from rehab. And there's also over 100 survey questions that they answer. So that leads to manual motor testing 3 times. That's 60 muscle tests. We test their skin with a cotton swab, 168 dermatomes. And we also do a pinprick test 3 times. That's another 168 dermatomes that we test. And so how much of this informs us about neurogenic bladder? The answer is 0. This does not inform us at all about neurogenic bladder. So let's summarize this important part. Neurogenic bladder is the #1 research priority for people living with spinal cord injury in the United States. 95% of people with suprasacral spinal cord injury will develop detrusor hyperreflexia and/or detrusor sphincter dyssynergia. 50% of these people will develop serious urologic complications, and none of the studies that we do, per usual care, inform us about the bladder. And all that leads to this gap in knowledge. One of the other big issues that we have is that there are these myths about neurogenic bladder. And I think in this era, I think it's fair to call it fake news. And coming from the United States, we have the king of fake news, who loves to share on Twitter. So the first neurogenic bladder fake news that I want to mention is found in people with acute spinal cord injury, and they're said to have bladder areflexia. So in 1998, this was disproven. They took 44 patients within 14 days of their injury, and they performed urodynamics on them, and only 45% of them, so less than half, had bladder areflexia. And 25% already had symptoms of neurogenic bladder with detrusor overactivity like DH and DSD. This was repeated 20 years later on 54 patients where urodynamics was performed within 40 days of spinal cord injury. And similarly, they only found 37% with bladder areflexia. And at this point, within 40 days, 63% had detrusor overactivity. All right, fake news 2, the physical exam. Physical exam correlates to neurogenic bladder function. Now, in 2018, 60 patients with acute spinal cord injury had urodynamics performed. And they divided the two groups into ambulatory and non-ambulatory, right? You can't get more gross than that. And they found that they could not tell the urodynamics apart between the two. They had similar risks of negative urodynamic outcome measures. On top of that, physical exams that they performed that have been said to reflect the bladder function were insensitive, like the rectal pinprick sensation and the bulbocavernosus reflex. They don't tell you what the bladder is doing. And my favorite, fake news 3, is regarding complete spinal cord injury. People with complete spinal cord injury lack bladder sensation. False, right? We know this if we care for people with spinal cord injury, but it's also been shown in the literature. In 2004, they performed urodynamics in 73 patients with complete spinal cord injury. I'm sorry, in 73 patients with chronic spinal cord injury, and in the complete ones, 40% had sensation. So we don't know how it develops. There's some myths that or fake news, which kind of contributes to us thinking we know what's going on. But in reality, we don't, and more research has to be done. And definitely careful monitoring. We are much better at management of neurogenic bladder, so that's the next thing we're going to talk about. Okay, so management of acute spinal cord injury. Our patients can still be in spinal shock even as far out as 3 months. So it is recommended to put an indwelling Foley catheter, especially because in the early periods of spinal cord injury, patients are having surgeries, a lot of fluids are being given to patients, and people can't possibly intermittently cath them and keep up with all those fluids. So a Foley catheter is totally fine in that acute period. But they should transition to clean or sterile intermittent catheterization whenever possible, or when training is possible. Training would involve time voids with straight caths every 4 to 6 hours. That largely depends upon the volumes. You want to keep the volumes less than 500 cc's. We can begin educating patients on clean intermittent catheterization. And I wouldn't try to rush into trials of spontaneous voiding, especially if we don't get return of sacral reflexes. When we do have bulbocavernosus present or anal wink, we can at least think that the sacral reflexes to the bladder may also be intact. So it would be fair to try return of voiding, especially if they have bladder sensation of fullness, or when they are getting cathed, or if they can feel the Foley catheter in their bladder. In the subacute period, so beyond 3 months to about a year, at that point, we should have all our patients seen by a urologist. It's very important that they get a urodynamic study, primarily to understand what their bladder pressures are. We want to make sure that their lower genitourinary tract doesn't damage their upper genitourinary tract, right? Their kidneys. We want to save their kidneys. And if their voiding pressures are elevated, or if their filling pressures are elevated, that can lead to kidney damage. And before we knew this, around the World War era, and patients were surviving spinal cord injury, many of them were ending up on dialysis because we weren't aware of how the lower genitourinary tract can impact the upper tracts and cause kidney damage. The urodynamic study also tells us about the general bladder and sphincter activities, the capacity of the bladder and its compliance to stretching, and of course, sensation. In this period, we can also educate our patients specifically about the volumes. They should hopefully be at home at this point, and we should make sure that they're keeping their volumes under 500, their techniques for intermittent catheterization, Speak to them if they are using Crede or Valsalva, so increasing abdominal pressure to empty their bladder. That is okay for some patients, but it should be based on neurodynamics, because abdominal pressure increases the bladder pressure, which can increase the detrusor pressure, which can lead to kidney damage. So if they're using Crede and Valsalva to empty through the urethra, we have to make sure that it's safe. And then, of course, autonomic dysreflexia. The bladder is one of the main triggers of autonomic dysreflexia. So they can't use dysreflexia as a means to signal it's time to catheterize. They have to be doing that well before their bladder is full. Finally, this is a good opportunity to talk about urinary tract infections, to treat or not to treat. We'll talk about that later in a little bit. So in the chronic phases of SCI, we want to make sure that their bladder capacity is good, and we might want to increase it. So something like anticholinergic meds or Botox are good options. If they're bothered by autonomic dysreflexia, and it might be a spastic bladder, something like an alpha blockers, or even Botox can help with that. And if they're getting frequent UTIs, there are some non-antibiotic medications like D-mannose, a sugar, can treat E. coli UTIs, or actually it can prevent overgrowth of E. coli because it binds, the E. coli bind to D-mannose, which are excreted in the urine. So rather than remaining on the bladder walls, the E. coli are excreted with the D-mannose. We can acidify the urine with vitamin C and cranberry tablets. And then in very rare cases, antibiotic prophylaxis is performed. We really discourage that because we don't want to lead to resistant bacterial strains. So the treatment of UTI, all patients who use a catheter will have bacterial colonization of their bladder. Most of them will have a positive urinalysis and a urine culture. So if they go to their physician, they go to the emergency room, and they have to give urine, it's going to be positive, and they might say, that is the reason why you're having symptoms. It's because you have a urinary tract infection. So it's important for the patient to be aware of what their symptoms are and to not treat asymptomatic bacteriuria. So also, not only can it delay the true diagnosis of what's really going on, but it can lead to the development of antibiotic-resistant strains. And so if their symptoms are something that are relatively benign, right, like sediment in the urine or foul-smelling urine, they can probably get away with simply increasing their fluid intake or flushing their bladder, and that can reduce the bacterial load and prevent the UTI before it occurs. The way I try to educate my patients is that their bladder is colonized by bacteria. There's nothing they can do about it. So what they want are to have the good bacteria there. If they take antibiotics and they get rid of the good bacteria, there is a good chance that bad bacteria are going to come. And the bad bacteria are a problem, and they can cause infections. So the good bacteria may prevent the bad bacteria from being present in the bladder. We treat our UTIs based on urine cultures. The urine culture might have multiple organisms. The lab might say, no, we're not going to run the speciation and sensitivities. But we know that our patients do have multiple organisms, so they should run it, so we know how to properly treat their urinary tract infections. Up to 5 UTIs per year is considered normal. More frequent than that would require further evaluation, like an X-ray and ultrasound to look for bladder or kidney stones. And if these UTIs are accompanied by other changes, like change in their sensation, their neurologic level, their motor scores, we would want to repeat the Izinski exam, that spinal cord injury exam, to make sure they don't have syringomyelia or syrinx. Okay, so now on to management of the bladder. We're basically treating overactive bladder symptoms. So the first line is going to be our anticholinergic meds. They work. They decrease the bladder contractions, they increase capacity. They say about 50 cc's increase capacity. Compliance, so it stretches better without a reflexive contraction. The pressures are better, decreased symptoms of urgency. One of the most first line meds that we use of these first line meds is oxybutynin. The newer they are, the more expensive they are, but they may have less side effects, which is a big deal. So there is no difference in the efficacy of these anticholinergic meds. So you just maximize the one that works, and then you can add others if needed. They did find that there's less side effects in many of these. So if you use long-acting meds that have like an extended release or sustained release medication, they may have less cognitive side effects. They even found that some of the meds have less affinity to the salivary gland. So although they bind to the bladder receptors the same, they bind to the salivary glands less, so there's less dry mouth. And it's important to note that we should be using these meds even in patients who have an indwelling catheter. So although they might not be complaining of leaking or urgency or any discomfort or bladder spasms, it will help with bladder compliance, hydronephrosis, and even less febrile UTIs. The next line of medication we like to use are tricyclic antidepressants, and that's really using them for their side effects. Imipramine is the one that we use often. It has muscarinic properties and beta receptor properties, so relaxing the bladder using two different receptors. We don't use this by itself. We usually always use this combined with an anticholinergic medication. Should your patient have nerve pain, consider using nortriptyline or amitriptyline, because we know these work for nerve pain, but their side effects can help relax the bladder. And it's noteworthy that although it's an antidepressant, we're not using these at a dose close to modify their mood. If a patient is depressed, it's a great idea to use these at a higher dose for depression, because you still will have the side effects that might improve the bladder symptoms. All right, the other type of medication are your alpha adrenergic receptor blockers, your alpha blockers. These are for really special cases where you're concerned about the bladder neck activity and the prostate, or if somebody has just a very irritable bladder, where you think that the bladder contractions are stemming from that bladder neck, and if you can reduce that bladder sensation, then perhaps a lot of the other overactive symptoms will reduce. They have been shown to improve pressures and flow rates and even reduce autonomic dysreflexia symptoms. The side effects include nasal congestion, dizziness, hypotension, and abnormal ejaculation. I don't know if I mentioned, but for the anticholinergics, side effects, dry mouth, sedation, constipation. That's going to be what leads patients to non-compliance for the most part. So now other medications, newer one called mirabegron or Myrbetriq. It's a beta-3 adrenergic receptor agonist, so it relaxes using the beta-3 pathway. But the side effects are hypertension, tachycardia, and headache. It can really look like autonomic dysreflexia. So if you have patients who do get dysreflexia from their bladder, I don't use it. And really, there's very few spinal cord injury studies to support using it. In fact, most insurances don't approve this medication for spinal cord injury at this point. And then another medication that I reserve is hyoscyamine. It's an anticholinergic. It specifically helps people for the feeling of spasms. So if they have bowel or bladder spasms, which in our population might be tough to distinguish, it's worth trying. But there really are no human randomized controlled trials for neurogenic bladder. All right, finally, Botox. Botox is great. It works well. It's said to improve the capacity of the bladder up to 200 cc's. But it is a procedure. It is expensive, and people have to know how to do it. So not everybody can have access to it. It has to be repeated. But I do like it, and hopefully one of these days it'll be easier to get for our patients. So this is from the package insert of Botox. They do recommend antibiotics before and after and during the treatment day. We do that as well. They do recommend 200 units. They give you the exact way to provide it, similar to how they do for migraine headaches, very similar to this kind of diagram, but obviously it's the neck and the head. It works longer than it does in skeletal muscle, so 42 to 48 weeks. So most of our patients get reevaluated at around 6 months. But you can be reevaluated sooner. They say no sooner than 3 months. So really great, but it does come with a procedure that can lead to urinary tract infections. All right, so conclusions again. Assume everybody with spinal cord injury has neurogenic bladder. The physical exam does not reflect the function of the neurogenic bladder. They have to be seen by urology. Urodynamics have to be performed to really get a sense of how to treat your patients. They're all going to have a positive urinalysis and culture, but if they don't have their UTI symptoms, which is different for everybody, don't treat the urine. You might be missing something that's life-threatening. Gallstones, appendicitis, fracture, you name it. Don't blame it on a UTI. And please monitor the status of their bladder, because if left uncontrolled, the bladder will devolve and have irreversible changes, which increase morbidity and decrease quality of life. And that kind of leads us into, I believe you're having a talk from a urologist that performs surgeries. If it's an end-stage bladder, which can't store urine well, not even Botox is going to help. They will need surgery. All right, thank you. I guess I'll be answering questions at some point.